Good afternoon, everyone. Good late morning. I think that covers all of our time zones. It is really, really wonderful to be gathered here today with this group of people and all of you attendees. We're really excited to see all of the interest in this topic, though not shocking at all, given the lineup for our conversation today. My name is Lily Armstrong. I'm a senior manager with NASTAD's Drug User Health Team. We're really excited to be presenting, hosting, co-facilitating this webinar that will go on for the next 90 minutes. We have a wonderful panel of speakers assembled today, and our conversation will be moderated by Maya Jo-Simpkins. What else feels important to cover? You are welcome to use the chat box, share questions, feel free to provide any kind of feedback. We definitely want to be hearing or sharing information that is most pertinent to programs and people who are supporting direct work and public health systems. So please feel free to share where you all are coming from and what you're seeing in your communities. We have kind of map of areas assembled today. We have some epidemiology and surveillance represented, some program-based drug checking techniques and models to discuss, and some observations from how the drug market has changed both in the last several years and specifically over the course of the pandemic. So with this, I am going to mute myself. You are also welcome to follow up after the webinar with Drug User Health TA at nastad.org. We'll put that in the chat box with any questions or TA requests. This is being presented through the National Harm Reduction TA Center. So thank you to CDC for allowing us to all assemble here, and really excited to get us started. Thank you, everybody, and thank you, Maya.
Oh, it is so exciting to be here with you all. Thanks so much for coordinating this, the whole NASDAD crew. This is going to be a great, fun, and fascinating conversation. My name is Maya Jo-Simpkins. I'm joining you from northern Lower Peninsula, Michigan. I've been working in public health and drug user health and wellness, including syringe services and overdose prevention stuff for about 20 years or so. I currently, one of my current roles is I help co-coordinate with many other people the Alliance for Collaborative Drug Checking. So that's a brain trust, a learning community that we've started up to help us understand a little bit more detail the rapidly changing and geographically variable illicit drug landscape. So I'm really, really thrilled to be here today with several fascinating and exciting folks. Jenscheinfeld is going to talk to us about a little bit of her epidemiology work in Philly. We're going to have Don Jackson and Mary Figgett talk about some of the amazing drug checking work that they've been doing in North Carolina using advanced technology spectroscopy. Louise Vincent from the Greensboro Urban Survivors Union is also going to talk to us a little bit about weaving together the academics and the user union folks in doing some of this work. We're going to have a little bit of a conversation from Alexandra Salgado, who's from Intercambios in Puerto Rico. And I feel like one of the things that I'm really excited to just talk a little bit more with her about is, you know, they discovered the Xylazine in their dope in like 2006. So we have a lot of historical knowledge about some of the things that has been like recycled and recurring over time. And so it's a great opportunity for us to not forget our history and learn from folks who have some historical experience in some of the things that we're currently experiencing. Hopefully near the end of our conversation, we'll have some folks with some street-based wound care experience and expertise to join us during Q&A. But if not, I already can tell from not only this group of panelists, but also from the folks who are joining us that we have some wound care expertise. So we'll look forward to having some more specific conversations on that during our Q&A session as well. So with that, I think I'm just going to hand it over to you, Jen, and then we'll take it from there.
Thank you. Hi, everyone. My name is Jenscheinfeld. I'm a field epidemiologist. I work for the Philadelphia Department of Public Health in our substance use division. I've been here for 2 years. Prior to this, I did 10 years of research in HIV and hepatitis C with the health department as well. So within the drug supply in Philadelphia, we started to see Xylazine back in 2006 as we noticed it. And that showed up in several decedents. And that's when our ME started tracking it pretty closely. And since then, we've just seen a rise and increase in it. Since November of this year, or 2020, I'm sorry, the health department has actually taken on a drug checking program where we do we take street-based samples, and we've partnered with the local lab to do that testing as well. This would be, I'm much better at conversation. So if anyone has any questions while this is going on, please feel free to ask them. But in regards to Xylazine, since we have seen that for such a long time in Philadelphia, we've noticed that it's been detected in almost all of our zip codes across Philadelphia since 2006. And in addition to that, since fentanyl took over our drug supply as well, we've seen an increase in Xylazine because it affects the way that fentanyl, it affects the fentanyl high in individuals. Yeah. Again, much better.
Jen, do you think you could go into a little bit more detail about that, specifically about how it affects people's experience with heroin and other opioids?
So fentanyl started to take over our drug supply back in 2006, and heroin has a much longer high for individuals. And so once fentanyl started to hit our streets, back in 2006, I would say we only had about 3 fentanyl corners. And once slowly we started to get more and more fentanyl corners, Xylazine started to get added more and more into our drug supply to help mimic a heroin high. Because what Xylazine does is it increases the nod that people have because it is a tranquilizer. So it's not called Xylazine, it's called tranq. So what we have now in Philadelphia is effectively what we call tranq dope. And in our testing, what we're finding is that a lot of our bags are 10 parts tranq to 1 part fentanyl. And that's really all that it is. I've spoken to some of our porter boys in certain locations, and some of them are only pushing out tranq bags sometimes, which just becomes effectively very unsafe for individuals who are opioid dependent. But that's why there was an increase in tranq to help people mimic that original heroin high that they were used to experiencing.
May I ask a quick question? Hi, I'm Daniela. I'm from the San Francisco Bay Area where fentanyl is sold as fentanyl and people use it intentionally. Can you tell me, is this being sold as heroin, or what do people think that they're buying?
Oh, people know that they're buying fentanyl now. Back in 2006, no, but everyone knows that they have fentanyl, and now everyone also knows that they're buying tranq as well. So it's all common knowledge as to what it is. But back when we were making that shift in 2006, which I mean is effectively almost 15 years ago at this point, it was an unknown new entity. So it's kind of like you would search out a fentanyl corner, and now in Philadelphia, you search out a heroin corner.
Sounds familiar. Thank you.
Yeah, I'm sure there's other very similar stories.
Here in Greensboro, they think they're buying heroin.
Yeah, I get people that bring me bags that go, I think that this is a heroin corner. Can you please test this so that I know if I'm being sold heroin or not? But effectively also what we're seeing with the increase in tranquilizer, we're also seeing a huge increase in the number of SSTIs that are on the streets as well. So since we can see that in 2010, we had less than 800 people that were going into the ER systems with SSTIs. And in 2019, we had over 1,600 individuals that were showing up in the ER systems with SSTIs, which is a huge correlation. Oh yes, skin and soft tissue infections. So abscesses, wounds, things like that. And a lot of people don't want to say that there's causation with tranq, but there's a very strong correlation between those things.
Can I ask a question?
Please.
Sorry, there's a lot of people. I don't want to interrupt. I have a 2-part question. My name is Brad Fang. I work for public health in Seattle and King County. So we're starting to see Xylazine in our drug supply. Can you talk a little bit about like what form it's coming in? Is it coming in mixed in like powder? Is it
We're seeing it mixed in our dope, so it's coming in powder form. And one of the unique things about it when it does come in our powder dope is that if it gets wet, it turns tacky. So the dope bags will stick together more so. You'll be able to tell that if there is tranq in it because it does come in a liquid form to begin with, and they turn it into a powder. We're also seeing it show up in our cocaine supply as well. You can imagine those corners get shut down pretty quickly because who wants to put a tranquilizer in their stimulants? But you're seeing it show up in that as well.
So I think that, I mean, this is just such a perfect example of kind of the perfect cut, right? So the perfect cut, the perfect bulking agent is one that to some extent mimics the substance that it's mixed with, right? Xylazine's a perfect example. Diphenhydramine is another example. The levamisole and cocaine is another example. Like this is, there's just pure bulking agents. And then there's the bulking agents that are active and have some mimicking effect. So that's kind of like the best cut, if you will. And then there's the downsides, the negative effects of that particular additive. Can you tell, oh, sorry.
Oh yeah, no, I mean, some of the other negative effects of that is it highly affects the respiratory system. So this really changes the way that overdoses present. So it really depresses respiration in individuals. So a lot of the overdoses from these really tranq heavy bags, and it's very difficult during COVID, but we really push for people to do rescue breathing because even though there's such a small amount of opioid, just the way that those interact, if you can use Narcan on someone, their respiration is still so depressed that you want to make sure that you're doing that rescue breathing just to get their pulse ox back up to a point where they're able to wake up. But you know, with COVID there, you're kind of like, oh, we don't want to have you do that rescue breathing in this situation. But so it's been a kind of an ongoing battle, especially since tranq got so heavy during COVID for us. Yeah.
I have one additional.
Oh, go ahead.
Oh, you go for it.
So we've had some consumers, bring in dope that we knew wasn't right. Just the texture, and it had that stickiness, which at the time we had no idea, right? But in terms of a way for people in the response to overdoses, right, we were seeing a very hypotensive reaction in terms of it, and that's what kind of like triggered like something's not right, because it wasn't like a hard nod off. It was very like reports of instant dropping, like it reminded me of somebody going hypotensive in like the hospital. Is that a good indicator for other individuals, or is that just kind of like what we were saying?
I mean, I call it tranked out at a certain point, because if you can tell someone is still breathing, but they're just like very far out of it. That's why one of the pilots that we ran out of the health department was getting everyone pulse oxes to know whether or not you needed to Narcan somebody, and doing education throughout the community to say, let's look at people's pulse oxes before we just start Narcanning everyone, because they don't necessarily need it. But you will need to sit with individuals longer, because being tranked out can last for an hour to 3 hours sometimes, depending on how many bags they did. I don't know if that answered your question. And yes, I have seen vomiting with tranq.
So here's a question that is, I feel like it makes a lot of sense to be also having a drug checking conversation during this panel is, so it sounds like it's relatively widespread and the people who use drugs in that community are relatively familiar with it. But do we have a sense of like actually how widespread? I mean, I feel like there's this sort of fatalistic notion that it's in everything and everything's super. So can you speak to that?
So with the drug checking that we've done, we sent out 175 dope samples since November, and all of them have come back with tranq in them, as well as fentanyl. So it's that widespread. And I'm getting reports back now from some individuals in Camden that they're now switching their bags over to tranq as well. And we test different geographies. I know that it's very heavy, like our Kensington area, which is our huge open air drug market, but it's also happening across different geographies because a lot of the drug market does stem from this area of the city. And I mean, looking at our overdose deaths, every individual that overdosed with tranq in their system also overdosed with fentanyl in their system.
That's a really key point that I think answers this question has been asked a couple of times about, does naloxone or Narcan work on xylazine, AKA tranq? And I think that that's like super key, that technically speaking, we don't think it works on xylazine. I mean, this is not something that's been robustly studied. I mean, naloxone is an opioid antagonist, so it probably not, but given the extent of the polydrug use, and the opioid involvement in all of the overdoses that you're talking about, naloxone is absolutely still warranted in any scenario, right, where we think it might be have opioids involved.
Yes. And that's why we highly encourage all of our individuals to carry pulse ox on the streets. So any outreach workers, even any laymen, we encourage. I mean, also, you know, COVID, everyone's supposed to be carrying them anyway, because all of our pulse oxes are for shit now after COVID. So
one last sort of transition question is, can you just walk us through what it might look like to use a pulse ox in the community? Like, let's just use a scenario where there's a outreach worker who comes across somebody down. Like, how would they use it, and how quickly would they get the information?
So if you have someone that you believe is experiencing an overdose and they're not like clearly overdosed, like blue lips or complete, you know, not in an obvious overdose, what we recommend is using either the middle finger or the ring finger. We say to avoid the pointer finger, because that finger is most likely to be calloused. So you're not going to get an accurate read on that one. Turn it on, depending on the pulse ox that you have. Obviously, go for a better quality one. You can buy ones for $7. I would not recommend those. If you have like an FHA card, you can purchase it with that. You get the read in 15 seconds. It'll give you what their pulse ox is. It'll also give you beats per minute on them as well. And if their pulse ox is low and they happen to be lying in an odd position, like head back like this, if you put them into the rescue position on their side, that opens up their airway, and an individual starts breathing more clearly. I've had people go from a pulse ox of 60 to a pulse ox of 92 within 5 seconds. So that can make a big difference.
Sorry, do you mind explaining like the thresholds at like what pulse ox would you say, you know, this is a situation where Narcan is warranted, like 85, or do you have any read on that?
We recommend below 88 for Narcan. So pulse oxes are also not perfect tools. Nothing is a perfect tool, so always monitoring for other signs of an overdose. But there's a 2% standard of error for individuals with darker colored skin. And they also will not read on women who have like gel nail polish. And there's also a standard of error for darker colored nail polish on individuals. So I have been known to rip off the nail.
It's worth it though. Jen, thank you so much for sharing that information. I think it's a perfect segue to hand it over to our friends and colleagues in North Carolina. The Urban Survivors Union has been absolute vanguard, at the absolute vanguard of overdose prevention response, of supervised consumption support, remote and in person, just incredible innovation. And I think that one of their current innovative initiatives is doing the advanced technology drug checking at their program in Greensboro, North Carolina. So with that, I'm gonna, and please know everyone that there'll be ample opportunity to talk more with Jen and everybody as more ideas and questions come up during the course of this workshop. And if you are interested in an in-depth technical assistance request, please reach out to the NASTAD Drug User Health team as well. So I'm gonna hand it over to the North Carolina Urban Survivors Union and associated university folks.
Hi everyone, sorry, I'm just trying to figure out my screen sharing situation. All right, cool. So I'm Mary Figgett. I am a PhD student at the University of North Carolina, and I work with the Urban Survivors Union, specifically the Greensboro site. And Don and I will be talking a little bit about drug checking here.
Yep. Don Jackson with the North Carolina Survivors Union in Greensboro. I run the SSP and work with the FTIR machine down here.
Yeah.
So let's go.
All right, great. So we're just going to start off by talking about some of the overall benefits of drug checking. Don, you want to take it away?
FTIR, what? Oh, was I going first?
Yeah, I think so.
FTIR. So the FTIR and the mass specs are necessary tools to expand our knowledge beyond what fentanyl test strips tell us, which studies have shown that drug checking encourages safer drug use practices. People who use drugs can address their drug use behaviors, make informed decisions about their health, and implement some harm reduction practices, which we'll talk about some more here in a second.
Yeah. So just to give everyone a background of some of the different technologies that we use for drug checking here in North Carolina, a lot of like where it started was with fentanyl test strips. And this was something where Louise and North Carolina Survivors Union really paved the way here in North Carolina and did a whole lot of work to do some research to support this practice. So they're going to talk a little bit about the results from that. And then kind of from their experience there, they really pushed the envelope to expand and get a machine that's called a Fourier Transform Infrared Spectrometer, an FTIR. And so that's something that we're using now. And we'll talk a little bit about like what those capabilities look like. And so these two things are really led out of NCSU. And then where UNC plays a role is we use gas chromatography mass spectrometry at our lab. And we're figuring out ways to work with some of the samples that are run on the FTIR to do some confirmatory testing. So all three of these technologies are really important. They have some strong benefits, but each of them has their own set of limitations. So it's important to know that these things work in combination with one another. And, you know, while fentanyl test strips only tell us whether or not fentanyl is there, the FTIR will give us like a much wider range of different substances we can look for. And it's also really quick. So we can get people results back in, 5 to 15 minutes, which is a really great service to be providing. And then mass spectrometry comes in to play because it does this confirmatory testing where we can look for new potentially emerging substances in the drug supply and get like much more detail of what's coming out of there.
Find some things that our FTIR won't find.
Yep, exactly. All right. Don, you wanna
drug checking? Our guiding principles. Drug checking is a service for people who use drugs in our community, around our surrounding community. It's centered in public health and harm reduction, and helps monitor the drug supply on a community-based level and surrounding areas.
Yeah.
Text. Yeah. So fentanyl test strips. Well, we did a research study with the Research Triangle Institute and John Zabel and with the fentanyl test strips, and so which led to participants led to them using test shots before using and pushing slower, and some even snorting instead of injecting.
And one of the things that's really neat about our findings was just the act of testing itself, just testing the drug. You don't have to worry about the results. Just testing the drugs resulted in changes in behavior. So we thought that was really cool. And so we knew from just doing our work with the fentanyl test strips that like to have better testing equipment would be amazing.
Yeah. Nice. And in getting ready to expand drug checking services, these are some things we needed to do to get ready, which was okay, the Opioid Response Act, which allowed for drug checking materials such as fentanyl test strips and such. Not the FDR, but they created a team. You needed to create a team. We were determined to have a staff member of North Carolina Survivors Union part of the FDR team, so no one could ever say that drug users can't operate a drug checking program. We had to assess our legal standing and develop relationships with like outreach to talking to our district attorney. And then next was purchasing the FDR machine, which we had little understanding of how intense the training and work would be to get up and running, which it's not that intense, but
It's pretty intense.
A little bit.
I thought it was pretty intense.
So then we had to secure the office to ensure that our FTR machine stayed where it is.
Stayed in the office.
Yeah, we've had some problems in the past. We lost a vacuum cleaner. Certain thing. So we purchased a double door, which is a big, solid, actually fire door with 2 deadbolts on it. And then you had to get a dehumidifier for the lab, because you have to run a performance test every time you start the software. Before running any test, it runs a performance test, and which I think every office would probably need a dehumidifier. And then we actually got rid of an extra door and made it a wall instead of a door, just to eliminate another entry.
We did.
Had to protect our participants in the FTR machine and North Carolina Survivors Union. So, to do that, we had to, which involved developing a protocol, which we deal with Mary and NAB. Well, they helped out big time.
Yeah, because originally we had people just bringing in like big bags of dope and like sort of setting them on the table, and we were like, well, this can't work. So we had to develop some protocol so they knew how to bring the drugs in.
Yeah, let them know how much we need to test. We don't need a gram.
Right.
But all right. Anyway, there's what it looks like.
Man.
And so at the International Overdose Awareness Day a couple weeks ago, we named our FTIR after Nan, who donated the money for it. Nan Goldman, the photographer. Everybody came down. It was a good time.
It was.
Yeah, it was the machine's debut. It was a
Yes, we actually
a good day.
Erica Paulette came and did her mojo on it, so it was real nice.
Yeah, had a naming ceremony and everything.
It was great. It was great. And Nan really liked the idea of like, go get Nan.
Oh yeah,
she loved the idea of, hey, everybody go get Nan. We need to test our drugs. She really liked the whole idea, so she was really thrilled, and we're really grateful.
Yeah.
Yeah.
What we got here?
So this is just kind of like an overview of the different things that drug checking can identify. So we like kind of try and divide things up into like active ingredients, inactive ingredients, and adulterants. Don, do you want to talk like a little bit about this?
Yeah. So those are, I mean, this is just some things like mainly what we are testing mainly. I mean, which is heroin, fentanyl analogs, meth, cocaine. Those are
The biggies.
That's about all we test. That's all I've tested so far. Besides DMT and some pills and and ketamine actually. I found ketamine in some heroin lately.
We found mescaline. in
And
some
I've been finding hallucinogens a lot lately in the heroin. I haven't been seeing as much xylazine. I've found probably to every 40 bags of heroin, I probably see 2 with xylazine in it, 2 or 3. I don't have a actual number, but that's probably close. Adulterants, yeah, xylazine, phenacetin, levamisole. Haven't been seeing a lot of levamisole, but you usually see that in cocaine. Levamisole looks exactly like the best cocaine you've ever seen, but it has no cocaine in it.
Doesn't do what cocaine does.
No.
Doesn't feel the same.
Yeah, and it's interesting, like, Don, I don't know if you or Louise want to talk about like how I think we saw levamisole in like a couple samples like at the beginning of the pandemic, and you know, we had some like thoughts about what was going on there.
Yeah, I mean, we just, at the beginning of the pandemic, we just saw all sorts of adulterants. I mean, there was just major, I mean, it was
there
like
was nothing real out there.
I mean, it was like the Wild West. I mean, it reminded me of when I was 14 and 15 trying to buy drugs, like just getting ripped off on the regular.
Yeah.
And people, I mean, there was such demand and there was no supply. And so people were creating supply. And people were wanting it. And so they were just taking it and doing whatever they could, but everything was cut.
Everything was fake.
Everything was fake. Everything was dangerous. And thank God we're moving away, you know, in a big way from that.
I have a feeling that maybe xylazine popped up because of the pandemic.
Right. That's the first time we knew we found it, but we didn't have the drug checking, you know, we didn't have the technology before that. So there's no way to know, but well, there is some ways to know because we can tell how things feel. And I had not felt anything quite like that prior to the pandemic. And so we really felt like it was something that was coming because of the pandemic, because they were selling xylazine as they couldn't remember in one of the batches of xylazine, they didn't even find fentanyl. We had to find it with the fentanyl test strip.
Yeah.
So it was mostly,
it was all xylazine.
It was all xylazine, which is really tricky.
Tranky,
awful, deadly.
All right.
Yeah, so I think that's a good segue into like what Louise said, like something that we try and emphasize here is the subjective experiences of the people that are coming in. I think something that, you know, we can talk about a little bit more, but like with the program that we started, we want to make sure that, you know, first and foremost, this is a service for people who use drugs, and that's like its primary purpose. Not so much like the research angle. And with that in mind, we really want to make sure that we capture the subjective experiences of drugs that are used, because that gives us so much more information than like what we might get just from like laboratory results on its own. So, I mean, these are 2 examples from things that we've come out with that really like ties in the you know, reported subjective experiences of people with the results. And I mean, just to say, like, generally, most things are kind of what we expect, but like sometimes we get these unusual things. So this isn't like necessarily reflective of everything. Don and Louise can talk more about that because they're doing much more of the testing on the ground. But recently we had someone with who turned in a sample for confirmatory testing where they had said they had like an unexpected hallucinogenic experience from heroin. And then when we went to test it, we found fentanyl, heroin, and then tenocyclidine, which is a PCP analog, and other cuts. So it's like very clear why that happened. And I think getting that information back to the person really validates their experience. And it's like a piece of information that, you know, they wouldn't have gotten elsewhere. So it's a really good thing to make sure that that's getting back to the person. You know, these things tie in really well together. And then something else that was similar, we had someone with, they used a small amount of heroin and it caused an usual reaction with deep sedation. This was also from a confirmatory test, and we found xylazine in that sample. So that was just like another situation where, with xylazine being kind of intermittent here, I think getting those results back out to people to let them know that it does show up occasionally, and, you know, to get that information out so they can be aware of what to look out for is really important.
And what's also important is that when we have people that don't have their drugs, you know, or maybe don't have drugs to bring in and get tested and checked, you know, we're able to say, you know, I'm very clear about what xylazine, what the effects of xylazine are, you know, a very dry mouth, some of these things that you can identify really immediately. In fact, we ran into it again, and I was able to determine, we didn't have to, like, we tested it, but I knew what it was because I had been told, and then I knew. And so subjective experiences are really important. A lot of times, I know for a while they said the drug users can't tell the difference between fentanyl and heroin and all these things, and we can, right? We pride ourselves on being able to tell the difference between drugs, and so being able to talk about this gets the word out to the wider community, places that don't have drug checking technologies, like being able to share these subjective experiences and getting people used to talking about them, because we're not used to talking about, well, was it this, or, you know, what was happening, and then identifying, but getting people used to doing that so that they can identify some of the more dangerous substances that they might find. I think this is one of the most important things we can do, as not everybody has an FTIR machine or a confirmatory testing available.
Yeah, I think that's an awesome point to make. So yeah, this is just kind of like wrapping things up, like some things that we've learned overall from our process. Don and Louise, do you guys want to like kind of talk about what you think our primary keys to success are?
Primary keys to success.
Well, I mean, I was just going to say, you know, this is what we talk about all the time. Like, it's us and it's creating a team, right? It's what Don was talking about earlier. It's the importance of having a team. Like, we can't do this without Don. We can't do this without Mary. We can't do this without Nab. We can't do this without Maya. We can't do this without, you know, all these teams that we build, you know, the call that we attend, you know. This is how we're able to do this, but drug users have to be included. And I think that's the most important key component for us, is us knowing that, like, this could easily be said, oh, researchers need to be the ones handling this, people with PhDs, people with chemistry degrees, and those people should definitely be around. Like, there's no doubt, but so should we, right? And we shouldn't lock community folks out of the experience. And so Mary and Nab and we were talking the other day about how do we talk about this so that people don't just look to Mary and Nab and forget that, you know, Don's in there doing this every day, and like, he knows plenty, and we can tell them what things feel like and talk about stuff like that, the subjective experiences versus what we find in really a more you know, I think there's some things we do better, right? There's definitely some things they do better, but there's, you know, we've got an area of expertise of our own that if it's left out, you only lose.
Yeah, I think like making sure that we're equals in this process and that we're like elevating each other is really important. There's, like, just to echo what Louise said, we both have expertises in different areas, and that's really powerful when we bring them together moving forward. And also, just like to reiterate what Louise said, we've had people come to us who are like, oh, you know, you must need like a chemistry degree to run this machine, but you really don't. And I think making sure that we let people know that drug checking is something that can be a drug user-led program is really important, to make sure that it reaches the most people, and in a way that, you know, is people who know the community are the ones that are communicating a lot of the findings.
I think the other key to success is the respect factor. You know, it's really about respecting, you know, the piece where we just didn't, you know, Mary and Nab didn't just turn this into a research project out the gate. Like, it was really important to us that the first thing we did, we were in the middle of a pandemic and we were in the middle of a crisis. And the first thing we needed to do was get information to people on the street right now. And we needed to have the safety in the program. We needed all these things right now. And to run a big research project was going to take a long time to get results out and get information out. And that's not what we were interested in doing. And so we weren't pressured to do that. And I think having love as a key research principle, it allows for that, right? Love and understanding that our community needs to stay alive. And that is more important than some of the other things, than publishing a paper right now. And it'll be a great paper later. And so we can do that. But right now we need to keep folks alive and we need to get them information. And so having researchers that care about that, or scientists that care about that, in our corner makes a huge difference, because otherwise we would just be pushing and pulling with researchers that only have their agenda in mind.
Yeah. All right. So,
Yeah. You want me to?
yeah, if you could take it away.
Yeah, so I just wanted to share just a little bit about in my experience with Xylazine and what happened. You know, as a person that uses drugs, I was not allowed to, I got thrown out of my methadone program while I was trying to transition over to buprenorphine so that I could travel and do some things. And so when I went back to get on methadone, because I was not able to make that transition, it's a really difficult jump to make. They said that I couldn't come back. And so I went to a different clinic and they put me on 40 milligrams of methadone and wouldn't let me go up. And so I was having to supplement while I was trying to find another, clinic. And so I was having to use drugs and I was having to use the supply that was out on the street. And I thought what I had found was this great analog of fentanyl that lasted all day. And this is the really scary part about Xylazine. I really liked it. Right? Like there wasn't a bunch of nasty side effects at first. It had a long half-life. I was able to stay well all day long, and I was able to work. I was not plagued with some of the problems you have with fentanyl that have such a short half-life.
And it wasn't knocking her out like it does a lot of people.
Right. I've been it's not blessed, it's the other with I have a sturdy, I'm able to do a lot of drugs and not feel them, I guess.
It knocked me out though.
Yes, it did. But, the FTIR machine really allowed me to be able to talk about this, because when we found out that it was poison, and that's what was wrong, because I was having all these crazy side effects, all these wounds that I've never had, all of this stuff that didn't make any sense. I mean, and at one point it had gotten so bad I couldn't walk from the house to the car. I couldn't breathe. I just couldn't breathe, and I couldn't figure out what was going on. And I'm not a big fan of the doctor. Many of you know I have a prosthetic leg, so I've had lots of experience with doctors. And I just, I was terrified to do anything. And, we got a new batch of something and I did it. And I said, there is something wrong with this. I mean, immediately, like I was having terrible side effects, and Don had just learned how to really use the machine and ran to the office and tested the supply, and it was all Xylazine. And then he started reading the side effects to me. And I was like, holy shit. Like, I mean, and at the end of it, it said death.
Yeah.
Like if you don't go to the doctor, you die. Yeah. Like basically is what, and that allowed me to call the people that I knew to call, which were like NAB and Mary and the folks that I had been working with, because we have this relationship. I was able to call people that I trusted and knew, and that knew and what a neat thing to have people, in your work life that you're able to talk about these things with. And so Nab and his wife, Roxanne, were able to get me to a wound care doctor, and they took my blood and they found out I had a hemoglobin of like 2.9, which is like ridiculous. They were like, we don't know how you're walking, talking, or doing anything else. And I was like, that's just me. And then, of course the hospital experience was what it always is. But the important part about this story is knowing that it was Xylazine allowed me to talk about some things that I wasn't talking about. I wasn't talking about the wounds. I was hiding these things. I wasn't talking about what was going on because I felt shame around it, But once I knew that I was being poisoned and that this was part of this, it really opened things up and allowed me to have some discussions that I needed to be having. And ultimately it saved my life. And I'm really grateful. So the FTIR machine and drug checking technology, you know, and I was able to tell Nan, like, this donation you gave, like, literally saved my life, like as we first got it up and running. And that was not something we expected. But I will forever be you know, I'm indebted to drug checking, and I'm indebted to Mary and NAB, and I mean, Mary got busy and like researched everything there was to know about Xylazine. I mean, she found out everything. Like, I mean, like, and to have that kind of access and to have that kind of team in place, like, my gratitude, just like, I mean, and Maya being the people that really introduced us to drug checking, like, all of this just comes full circle, and I'm just forever grateful for it. And so if you are considering having a program like this or have the money to do it, I highly recommend it. There is nothing like this machine that can say, I mean, there's nothing else like it. And it has, and the people that come in that do it, like, as soon as they do it once, like, they're totally hooked. Like, once you check your drugs, you want to check them every time. Like, I'm crazy about it now. Have we checked this? Have we checked that? I mean, and so it's kind of cool. So it may seem at first like people aren't into it, but once they start doing it, like, they will really want to know. And it's just proof positive to me that, like, we do want to know what's in our shit. We do want to know what we're using. We do, like, there's no part of us that just doesn't care. And having the ability to know that is everything. So I appreciate having a chance to say that. I think it's an important, like, story to tell as we think about drug checking, and as we think about, is this you know, something that we need to be putting in our programs? And my answer, and I'm sure Don's and Mary's and our team, is yes.
Louise, I hope you get a chance to see the love in the chat box, because in addition to me sharing some love, a lot of other folks are really
Thank you.
Appreciative of you sharing your story. And I just want to add, in addition to this, that I think that this narrative, not only is it awesome that Louise is still with us and the drug checking initiative had such an initial positive effect, but I also really want to point out that people who use drugs provide Eureka moments in drug checking in the presence or absence of advanced technology drug checking. This is our first line of information of something isn't right. Something's unusual, something's wacky. Even the, like, super schmancy, like, well-funded British Columbia Center on Substance Use drug checking initiative, when they discovered Xylazine in their opiate supply, it was because the people who use drugs told them something was different. And so, just to reiterate this, there's nothing that I've been involved in harm reduction that can so easily slide to hyper professionalization and academia as drug checking. It's a super easy slide to have it go in that direction. And I can emphatically say that without active involvement of people who use drugs in a position of influence and power in your drug checking projects, they're not going to be nearly as robust as they could be. And we're going to do our drug using community a disservice. So I just really emphatically encourage all of us to be really vigilant for not if, but when drug checking in our community slides into the hyper-professionalization or the marginalization of non-traditionally educated folks with experiential expertise, that we need to be really cautious of that, because it is the Eureka moments. So anyway, I think there's just incredible opportunities for partnership there. And so thanks for sharing that, Louise. And Alexandra, I am really excited to hand it over to you both to get a little bit of a, oh, sorry.
Oh, no, that's just our contact information. I think we're good. Thank you.
All right. Thanks for letting us share. We really appreciate it.
Alexandra is going to talk to us about some of the initiatives and current and historical experiences and intercambios in Puerto Rico. So thanks so much for joining us, Alexandra.
Hi, nice to meet you all. Well, my name is Alexandra and I am working in Puerto Rico in Intercambios Puerto Rico. Now I am the fashion navigator. And yeah, some of our maybe struggles in the drug supplies and what is the relationship of this with health. We obviously have our first struggle for that is maybe the access for treatment. And we know that if one person think that they are consume heroin or maybe fentanyl, it is an opioid substance. And when the people get to some treatment for medical assist for opioid use, well, we saw maybe in the toxicological test that the use that they are taking, it is not maybe heroin or fentanyl. This is the case maybe for the Xylazine. And here in Puerto Rico, well, I don't know in other part of United States, but here the Xylazine is sold like heroin in the first moments was selling. Well, if heroin now, the is a lot of different, because maybe in the drug market that you want Xylazine or you want fentanyl or you want heroin. It is like a lot of difference and different. I'm sorry for my English. The diversity of the market, of the drug markets. I think that this is one of the struggles to access treatments, because maybe the person don't know the diversity that they are consumed. And when you ask if the person wants maybe methadone or Suboxone, they think that the only that they are consumed is heroin or fentanyl, but we got cuts like benzodiazepines in some of the heroin toxicological tests. And we also have Xylazine, and obviously this is not opioids and it is not applicable with the MAT treatment. And this is one of our struggles here. And I think that it is important to say that we are here in Puerto Rico in an island, and we are a colony of the United States, and all the border in the island, it is guarded by the national coast. And all the drugs come, and a lot of these drugs go to the United States. So we hear about the drug supply. Maybe we got a lot of struggles maybe with all the prohibitionism talk and all of the market that it is incentivized about the prohibitions of that drugs. And yeah, we got the open door for take a lot of substance that people don't know what is taking. So this is the prohibition part of this, and the prohibition effects of in the consume process. If we as a state or a country don't enter directly to the different and the variants of the drugs, and the different consumes and the different effects that this create, we can't do investigations, we can do prevention treatments, prevention process, because it is only in the marginalized side and can take it with the prohibition part. And here in Puerto Rico, this part of the political effects of this statement of I don't want to do something with the effects that create the prohibition, take a lot of lives of a lot of young people that dead about the criminalization of the economy of the drugs. And yeah, this opened the door to get a lot of variants drugs like Xylazine that you were talking before, and the Xylazine, the effects of the in the body, the wounds, it is very critical process. It is not something that it is used for human use, you know, it was for animals. And this is something that maybe in the hospitals, in the clinics, in the primary care, the wound cares, here in Puerto Rico, the professionals are not ready to attend, are not, don't know how to attend people who maybe have physical necessities and use necessities too. So it is very maybe complicated scenario to attend. And the fentanyl here in Puerto Rico, it is in a lot of, I think it is in all the island. We attend in the northeast of the island, and we in some moments do the fentanyl strips. I know about another organization that do it the same process in around other organizations in the island, but in all of the different organizations we take the same answer, and it is that fentanyl, it is in all the island, maybe around 2 years or 3 years last, and the people don't in this moment don't know it, but it is like a harm reduction centers and the variety of harm reduction centers that it is minus in Puerto Rico. We only got seven in all the island, and the island is maybe it's small for compared with a state, but the problematic use or most the lack of access to people who use drugs, it is very big. And in Puerto Rico, the fentanyl strips, almost in Intercambios Puerto Rico, it is difficult to take the fentanyl strips to our participants. And I'm going to explain why, because we do it in some moment, but we have to recognize the community dynamics too, because in Puerto Rico, the market of drugs are something very, very near to our participants. Even our participants maybe work in these drug markets, and it is some complicated because of the normally barrier defense that or mechanisms of defense that the community take. They are not acostumbrados. I don't know how to say acostumbrados. They are not maybe open, but
they're not used
to something.
Used
acostumbrados,
to. Acostumbrados, used to, yeah.
Accustomed to.
Like they're not used to something, like they're not used to something happening, or like they're not like familiar with it, you know?
Exactly. They are very
I got you.
Yeah, thank you. And it is like we are very near of that line, and we don't want to destroy that confidence that the participants take to us. Yeah, we pass the message that it is only a form that you can be sure that what are you consume, but this have another consequence maybe in the community, because they maybe are doing some reclaims that why are you selling me drug that I don't want it or that I don't use it regularly. And this dynamics was very difficult in some moment, and we maybe prefer that they go into our organization, and maybe in this process of talk to the participants, if they prefer to use it, they can use it. Yeah, we know that we are a base community organization, and we have to recognize that the community have a lot of dynamics that we have to respect too. And yeah, it is like was some complicated in this moment. But maybe a lot of people that it is in treatments that want maybe to know that the potential of the consume that they are taking, it is only heroin, and be sure that they don't have fentanyl in the drug. It is important for these people too. And I have some points here. Let me see if, yeah, I talk about the lack of the treatment health and the effective alternative than the people take, and always the stigma and the ignorance of professionals make the cure worse than the disease. This is I don't know how to say in English, una frase en Puerto Rico: la cura es más mala que la enfermedad.
The cure is worse than the illness.
Yeah. Here in Puerto Rico, if you decide to do some process with some clinics, we in our geographical area got too much barriers to take it. And yeah, a lot of people say like it is better to be sure in my use, and they are some in the expectative, because the cut of the drugs change a lot in any moment, and it is very risky to be in this bit of, because maybe the people it is comfortable with some doses, and then if the cut it change in some moment, the people have risk of overdose, and it is because it is prohibition. It is not controllable. If we have regulation of the drugs that we consume, we can be more in control of what we are taking. Yes, let me see. Some of the points that maybe we can talk about the overdose in Puerto Rico. Right now, the Narcan, it is accessible to NGOs to take to participants. All people in Puerto Rico can have it. It is not regulation by professionals or first responders. In intercambios, we take the Narcan even if the law don't permit it. But yeah, we got to do it because we are seeing the overdose constantly, and we have to adopt the strategy of harm reduction to take the Narcan out of the organization, and all the participants who are in consume got Narcan in her pockets or in her bag. And yeah, this was like maybe since 2017, our project to start doing the Narcan community take it to our participants. And yeah, right now, in the last 2 months, in the public politics, in Puerto Rico, the Narcan it is accessible by administrative order, but by the law, now the police can't do interventions to arrest people who are using drugs in the space that where is to be an overdose. For example, if some people are using drugs and the people, one of them got an overdose, and the police come, or maybe have to be the ambulance, but in every moment in Puerto Rico come the police too. The police can't do the intervention directly to the people who are using drugs in this moment. I don't know if you understand me, sorry about my English. But it is law that the interventions that the police do in these moments are illegal. So this was 2 months ago, and yeah, it is maybe one steps. I think that it is atrasado. I don't know how to say atrasado, but we in Puerto Rico have a lot of deaths already for the overdose, and this is like a barrier to people to call 911 in these moments, because they know that they have maybe drugs in the scenario, and say like, we can take the call and we can save the life because we are doing this, but this is illegal right now, that the police can do this. Another maybe complication for the Narcan services is that people who use opioids with a prescription, the doctors maybe prescribe the Narcan, but in the pharmacies, it is very inaccessible to take it. It is not consistent, the law, with the reality in the pharmacies, because when the people may be going to take the prescribed Narcan in the pharmacy, maybe don't get it, or they are doing better calling like a non-governmental organization and take the Narcan, because the pharmacy, it is not ready to take and don't sell it a lot. I don't know if someone have questions, or I don't know if I got the time.
Alexandra, that you're perfect. It puts us right on schedule. I don't know if you were, it's confusing for me when I'm talking. I ignore the chat while I'm actually talking, but I hope you get a chance to see all of the love and serious appreciation for agreeing to do this in English. Thank you for that. We really, really, really appreciate it. And you did a great job. I wanted to just, like, the point that you made about the fentanyl test strips is so interesting. I feel like I've heard similar things, like what you were talking about, concern for the safety of the community, and drug sellers and drug users being pretty similar, and and having a lot of overlap, and not wanting to out somebody for having a shitty product, which oftentimes is not their fault, right? We heard the same thing from our friends and colleagues in like Mexicali and in Tijuana. And then when we were talking with our friends in Bogota who do drug checking there, they're like, we're not worried about that. We just partner with drug sellers anyway. And I was like, I'm sorry, I know I don't mean to like impose all of my preconceived notions on you, but you're not worried in Bogota about like pissing off drug dealers? Like, no, we work with drug suppliers. And that was sort of like a eureka moment for me, that if drug checking can easily and regularly access drug suppliers, drug sellers, this is when we get to a point of effect on overdose, right? I mean, that is the level where I can really imagine we can start to see changes in the supply, in the poison supply that you know, Louise and Don mentioned. So I don't know exactly how we get from needing to be really careful and cautious with our community members who sell drugs and not out them for having fentanyl or xylazine or whatever in the supply that they're selling, to totally incorporating them. But I feel like that that's one of our additional responsibilities as we roll out drug checking to try to make that happen. So can you tell us just like what would be maybe the situation where you would give somebody a fentanyl test strip, or you wouldn't? Like, if it were like a bigger city, for example, would that change things?
I'm sorry, I don't understand the question. Sorry, I know that I was reading in the transcript. Sorry.
As you should have. And also, I just talked for like forever, and the question was very short. The question was pretty simply would you give out fentanyl test strips differently in bigger cities than smaller communities?
Yeah, it is different. Maybe in our spots that we do our job, it is small cities, and everybody knows everybody. Everybody know each other, and yeah, I think the process to access of maybe drug sellers, it is maybe not bad, but we have to take a tricky, like we have to recognize and respect that we are not living in their communities, we are not in the space, and we are doing a job and efforts to benefit all the community at the time. Yeah. I think it is a process that it is with a lot of confidence, and when the community saw the effects that the programs give to the community, it is more accessible to open. And in Puerto Rico, we got a reality too, a lot of changers, people change in some drug sellers of drug markets, a lot of change of peoples too. And yeah, it is like we have to do a confidence job and a lot of outreach strategies, but maybe, yeah, I don't want to say like that, but maybe in one moment the drug dealer dead because of the drug wars, because or in some moment the police take out of the community this person, and we have to renovate the confidence to another people. Maybe in Puerto Rico it is a lot of young people, 15, 14 years, and maybe at this age they don't know the benefits of have some organization that provide this kind of service, because maybe it is they are looking for surviving economic in a lot of equality problems of economics, and they already have families, and they have to be very aware of what they are doing in this process. And yeah, the context of the community who sell drugs in Puerto Rico, it is something that maybe a lot of agencies, NGOs, or agencies, organizations maybe don't want to talk, because it is conflictive. It is not easy. We cannot say like it is perfect. It is a lot of rough strategies and environment. It is very hard environment.
No, you're absolutely right. I just got a DM as we were talking from somebody being like, I think you maybe have some like rose tinted glasses about people who sell drugs. And so I think that that's a really good point, that it is really complicated. And some, there's lots of dynamics that are going on with this major engagement in an illicit drug, in a drug war. And some people who sell drugs are deeply invested in the life and positive benefits of their customers, and other folks are a little bit less so. And I think that bringing it back to community, the way that you talk about is really key, like whether or not and how deeply and in which ways people are recognized as and invited to be part of a community. I'm aware that there's a couple specific questions that are way up the feed that I wanted to get to. So I'll just do two right off the bat. One is probably for Don and Mary. Can you tell us what your actual schedule looks like? Like how many hours a week, how many people run the machine, how many clients approximately do you get? And then after that question, maybe we can switch over to Jen, because I know you're gonna be launching a drug checking initiative. Can you talk just a little bit about state level policy, law, things that you had to do? No, Jen's like, no, how do you? All right, well, I think there's probably some other folks who are part of participants who could talk about that, but let's chat with Mary and Don first.
All right. So right now we're pretty much just getting started with testing participant samples, so I mean we get probably around 5, I mean, maybe 10 people a week.
And this is without us doing major advertising. Like we don't have big signs up. We're not putting the word out really heavily. We're going to start doing it more. After Overdose Awareness Day, that was sort of, we wanted to have pictures of the machine with state officials. And that way, when we got that. So, we wanted to implement, we wanted them, smiling about the machine and whatnot. So if the police came, we could be like, but wait a minute, here's the state attorney's wife. She likes it. So now that we have a little bit more, now that we have talked about it a little bit more and we have a little bit more buy-in, we're going to be making a little bit more noise about it.
And the only people who know how to run the machine are me and Mary and Nab. So far, I was gonna teach or train another employee, a guy that works with us. But I haven't gotten around to that yet.
I don't even know how to turn it on. So
yeah,
I hear that. So, this brings up a couple really key bullet points that I just want to highlight for anybody who's on this workshop, who's interested in launching or has some specific or is thinking about drug checking. One is training technicians is a steep learning curve. It is absolutely doable. It's absolutely doable with people who use drugs, but it's a steep learning curve. And so we need to plan for that and budget for technical assistance in your budgets. If you have any budgets, like a lot of folks are getting leftover overdose data to action funds or something like that. So budget for TA. The other thing that we didn't mention a huge amount, Mary mentioned it briefly, but I also wanted to say budget for this is confirmatory testing. So There's limitations of all of the field-based deployable technologies. Confirmatory testing is part of how we train and quality assurance our technicians. So do that as well. And then the piece, I don't know if you caught up on the super clever strategy of the North Carolina folks that we wanted to get images of our politicians and public health infrastructure folks joining us in doing drug checking, because there's no way to slice and dice it, that in many places, this is very much at best legal gray area. And in some places it's explicitly not legal. In a very few jurisdictions has legislation been rewritten to make it legal, but it is almost certainly, I've talked to all the public health lawyers I can find, and they're like, look, I know what you want to hear, but almost certainly the best I can give you is that it's gray area. So I don't know, Jen, do you have any more thoughts on that?
So we just got fentanyl test strips legalized in Philadelphia. So they will no longer be prosecuted as so anyone can carry those. And I wanted it to be pushed in a way that any drug testing, anything would not be. So this machine wouldn't be, but that didn't go through the way I was hoping it would. So maybe baby steps since that went through.
You know, I hear you. Yeah.
But in terms of what we're hoping for with this, I'm hoping that we're going to be able to get letters from like our SEPTA captain and things like that, because we actually purchased 2 machines for our program. Yeah, so we're going to have one for the health department to have sites up, as well as one of our mobile syringe exchanges. So we'll have 2 things up and running.
Great. I was just going to say real quick that you like, and the way participants talk about it too, you have to be really careful, because like they are looking for excuses to have drugs. And so if you don't share with them some of the information, they'll say things like, oh, well, I was just going up to, I have this drugs on me because I was going up to, up to North Carolina Survivors Union, and they told me to bring drugs up there to get tested. So that's why I've got this. And that can really create like backlash.
A big spider web. Yeah.
And at the same time, at the same time, if we don't actually make it legal to carry your drugs to the needle exchange,
right,
where people often carry drugs anyway, then we are then it's disproportionately cutting out people who are already over policed,
right,
from accessing our drug checking services. So, people of color, queer people, women, like we need to be really aware that if we don't make it legal to, in our hot little hands, have the stuff that we need, then we know that some people are going to get a slide and some people aren't. So we have one other question I wanted to bring up. And then I think it's probably after that going to be my turn to hand it back to the amazing NASTAD crew. So the question I want to bring up is, can you tell me about what's going on with stimulant checking? I like either in whatever other context that everybody's got it. What are you seeing? Are you seeing any trends with stimulants? Are you seeing any, what are you seeing in that area? And also around purity stuff. How's that going?
Philly loves meth now. I'll give you that much. We love meth, and our meth is really fucking pure and safe. I tell people, if you want to do a good drug, do meth in Philly now. Because I've tested a lot of fucking meth, and it's all come back pure meth, and it's at like 99.6% pure methamphetamine. So like, you want to do a drug that you know what it is, I'll give you, just do meth.
I get more meth than cocaine actually to test, and it's always every meth sample I've tested has been pure meth too.
We did have one of them
had fentanyl in it actually.
But it's important to note that person also used fentanyl and carried things
in the same container.
So you may have like the messy user
wrap up,
the messy user theory, which I think probably had a lot to do. It doesn't take very much fentanyl to alarm the machines.
Yeah,
I think what you all are saying is, there is a lot of geographical variation about drugs. That is true. Uh-oh, something weird happened to my. Okay, it's gone now. I got a weird echo. But the most consistent thing, which is not that consistent, but the most consistent thing I've heard is that methamphetamine seems to be relatively pure and coming out, like if you know, compared to the sold as heroin or the sold as cocaine drugs, the sold as methamphetamine drugs seem to be the cleanest or least complicated. How about that one? One wrap-up thing that I wanted to say before I hand it over to the amazing NASTAD team is that the Alliance for Collaborative Drug Checking, which is our, you know, our collective that everybody on here is on, we are having our annual virtual learning summit on November 3rd to 5th. And because I cannot type and talk at the same time, when I hand it over to the NASTAD team, I will find the save the date and put it in the chat box. I want to wrap up by thanking you all so much for joining us. You all are wonderful, and it's such an honor to sit here with you. And I would like to have the NASTAD folks remind folks how to access their incredible technical assistance. So that's it for me.
No, never mind.
No, you're.
I can say one other thing too. I've tested every X pill I've ever tested was fake, and I've been testing a lot of like a fake Roxy the other day, a Roxy 30, and a fake Xanax. So like most of the pills I've tested have been fake, and all the X.
Yeah, we don't have a huge like X or MDMA game in Philly, but none of it's legit.
And there's no real Molly ever.
Yeah, one of the first ones we tested was just caffeine.
Yeah, but DMT, the DMT has always been real.
It's good to go. We recommend it.
but that was mine. That's all.
Hey, everybody, this is Billy from NASTAD Drug User Health Team. I just wanted to say a huge thanks for everybody that was able to be on our panel and talk. And I want to thank everybody that could join in the audience. We will be sending out recordings. And if folks want to contact the Drug User Health Team, we can be reached at Drug User Health TA at NASTAD. And I'll just, that's typed in the chat box. And definitely please keep your eyes open. We would like to definitely do more webinars and trainings like this. So thanks again, everybody.
Thank you, everyone.
Really quick, I have a question. Sorry, it didn't seem like it was going to end yet. So let me turn my camera on so you can see me. Hi, y'all. My name is Anjanae Connor, and I'm the MSW intern with the Institute for Women and Ethnic Studies here in New Orleans. And I just had a question. It's slightly off topic, but I just kind of wanted to know something that I was thinking about. Do y'all have any information about how the pandemic has or is impacting people's access to contraceptives? Does anybody have any information on that?
So I'm actually doing a drug user health survey in Philly right now, and that's one of the questions that I'm asking. And there has not been a huge impact. In fact, it's easier because some more resources have been put in these locations for women, and online stuff is more available as well.
Okay, got it.
And that's specific just to Philadelphia, which I know is very different from New Orleans. So.
Right. Okay, great. Thank you. This was great. Thank you, everybody. Thank you so much.
Thank you. This has been fantastic. See you soon.
Thank you so much.
Thanks,
Good
everybody.
to see you all.
Thanks, guys.
Bye.
We'll be in touch for whatever is coming next.